Since we have attendees from all over the world, I'd like to say good morning, good afternoon, and good evening. My name is Larry Greenbaum, and I'm going to be introducing our Pediatric Renal Nutrition Task Force webinar on assessment and management of magnesium and trace element status in children with CKD stages 2 to 5 on dialysis and post-transplantation. I'll also be introducing our wonderful speakers. We do have some information to get out of the way. This webinar is intended for healthcare professionals only. The webinar will last approximately 60 minutes, which includes time for a question and answer session. Please submit questions anytime during the webinar by using the question box on your screen. Don't use the chat box. A certificate of attendance will be provided via email after the webinar. The webinar is being recorded. The recording will be available on www.vitaflowvia.com in a few weeks' time. Disclaimer, financial support for this presentation was provided by VitaFlow International Limited, a Nestle Health Sciences company. The views expressed herein are those of the presenters and do not necessarily represent VitaFlow's views. The material herein is accurate as of the date it was presented, and it is for educational purposes only and is not intended as a substitute for medical advice. Learning objectives today. At the end of this webinar, the participant will be able to assess magnesium and trace element status in children with kidney disease, describe the requirements and main sources of magnesium and trace elements in children with kidney disease, and plan the management of magnesium and trace element intake in children with kidney disease. I now have the great pleasure of introducing our two speakers. Carolyn, as you can see, is the lead pediatric renal clinical academic dietitian at Southampton Children's Hospital in the UK. She's been the lead there for 24 years, so brings a great deal of experience to this field. She completed her PhD in energy expenditure and requirements, physical activity, body composition, and nutritional intake and status in children with chronic kidney disease. She is undertaking ongoing research on nutrition biomarkers, quality of life, patient experience, growth, and micronutrient status. She is a member of the PRNT, the Pediatric Renal Nutrition Task Force, the Pediatric Renal Interest Nutrition Group, and the Kidney Quality Outcome Partnership. Our second speaker, Jetta, is a clinical lecturer at the University of Eastern Finland. She has worked for over 10 years as a pediatric renal dietitian and is currently working as a clinical lecturer at the University of Eastern Finland. She is a founding member of the PRNT and also has a PhD in nutritional epidemiology. She is involved with ongoing research in the field of nutrition and dietetics in children with regards to disease-related malnutrition, renal nutrition, nutrition in short bowel syndrome, and nutrition after organ transplantation. We clearly have two extremely qualified speakers today. And this is me. I'm the moderator of the session. I'm a pediatric nephrologist at Emory University and Children's Healthcare of Atlanta in Atlanta, Georgia, in the United States. And now I'm going to move it on to Caroline.
Thank you, Larry. I'd like to thank the task force, our Delphi members and our task force members for contributing to this today and having us here. Today we are going to focus on applying the clinical practice points to day-to-day practice. First, we will give a brief background on why magnesium and trace elements are important, what needs to be considered, the evidence base to date and what was done, and then we will relate this to clinical practice. So let's first look at why this is important. Magnesium and trace elements are important for essential body processes. They can't be made or synthesized by the body, and they need to be provided by the diet in small amounts. Children and young people are at risk of deficiency and excess, which is more common in chronic disease and can result in adverse clinical consequences such as poor growth. There are many factors that affect status, and we will be discussing these in the presentation. And finally, guidelines prior to these were 15 years old and more. This picture here just represents the varied functions and roles of these elements in the body. So what are the challenges that we need to consider? Well, moving on, we looked at 5 key areas when we were developing these guidelines. Firstly, definition, how we define deficiency and excess and classify normality. Secondly, how we look at assessment, dietary assessment, laboratory values, signs and symptoms, and the validity of these. Thirdly, intervention. That included food, supplementation, impact on kidney disease, and therapy goals. Fourthly, the evidence for all standards of treatment and previous guidelines available. And lastly, kidney disease itself, the impact of kidney disease. So just taking a moment to look at the guidance that we've had. As we said, the original guidance was over 15 years old. And this guidance looked at dietary intake, supplementation, blood markers and dialysis. However, there was a need to provide a review of updated information, relate to care today, and include some of the trace elements that were missing from the original guidance. The Paediatric Nutrition Task Force now has 9 papers on guidance and 5 educational papers, and whilst doing these it became clear that we needed to focus on magnesium and trace elements specifically. So what was included within these clinical practice guidelines was magnesium and the following 7 trace elements: chromium, copper, fluoride, iodine, manganese, selenium and zinc. Please note that these are the only ones in scope in this recommendations. Iron, sodium, calcium and phosphate were out of scope for these recommendations. To be consistent with the vitamin paper and previous webinar, because vitamins and minerals and trace elements are often considered together, we looked at the 3 key clinical questions that would relate to clinical practice. Firstly, what are the sources and functions? Secondly, how does the impact of modifications and non-dietary factors affect these elements? And thirdly, how will we approach clinical care? I'm just going to take a moment to highlight the evidence that was available in these next few slides. This is a bubble plot with a number down the x-axis and the different nutrients along the y-axis. The yellow represents, or the orange represents the serum values, and the blue represents the dietary intake values, and the numbers inside represent the number of patients. As you can see, there were some gaps in nutrients, and there were small to varying numbers of patients, and there were very different methodologies. If we just look at this in a little bit more detail, what you can see here is a table of evidence with the nutrients across the top, and each of the studies for diet and supplementation and laboratory values down this side, with each of the broken down into the modalities of treatment. So chronic kidney disease, peritoneal dialysis, hemodialysis, mixtures of dialysis and transplantation. The top box here shows diet alone and the results and findings from these. The arrows down represent deficiency, the arrows up represent excess, and the arrows along represent either similar to whatever comparison group they were using. The second box shows the results for diet and supplementation with the same breakdown and the same arrows. And the third box shows the biochemical status, again with the same breakdown and the same arrows. And as you can see here, there are large gaps in evidence. There is variable intake and blood concentrations, and as you would expect, dietary intake increases with supplementation. Moving on to our clinical practice points. We followed the same process as previous recommendations and consistent with the vitamin paper, and we have 6 clinical practice points that we're now about to discuss. Our first clinical practice point focuses on recommendations. What are the magnesium and trace element requirements? The challenges we had here is that there are no requirements for children with chronic kidney disease in regard to magnesium and trace elements. Our recommendations are that requirements should therefore follow that approximately of healthy children of the same chronological age as a starting point of initial prescription. However, for some children, they may require more or less than healthy children in terms of requirements, and this is largely due to the potential accumulation or losses of magnesium and trace elements. More specifically, in early stages, if dietary intake is lower than recommendations, you might want to consider using diet and or supplementation to meet these requirements for health. However, in advanced stages, where magnesium and trace elements and iodine in particular can accumulate, and there is low dietary intake alone, that may not be an indication for supplementation. Whereas on dialysis, where there are losses that occur, you may want to consider giving additional intakes. And these will be gone into in more detail in subsequent clinical practice points. Our second clinical practice point looks at the dietary sources, and our question was, what are the main dietary sources? And we recommend that the main dietary sources should be achieved from a variety, taking a varied diet and or nutritional supplementation. Our rationale for this is that dietary modifications may be used in the management of kidney disease, for example, uremia, hyperkalemia, hypophosphatemia, which all may restrict rich dietary sources. Our second slide here just shows you graphically some of the variety of sources that foods may provide. You have the food groups down the left hand side, and you have each of the nutrients across the top. As you can see, some of the nutrients are widespread in various foods and some are only in particular food groups. If we just give you some examples here and some more things, more practical examples, what you can see that copper can be found in protein foods, but also nuts, seeds and vegetables. Iodine can be found in soil and ocean sources, including animal protein, fish and dairy foods in particular. Selenium can be found in soil and animal protein and includes meat, nuts, seeds and fish sources, and zinc can be found in meat, poultry and seafood, but also corn, nuts and seeds. Moving on to clinical practice point 3, our question was, how do modifications affect intake? And we suggest that dietary modifications in food preparation may impact magnesium and trace element intake. The reasons for this can be broken down into 4 key areas: dietary intake, nutrient interactions, dietary modifications, and food preparation. Dietary intake of magnesium and trace elements has been reported to vary from ranging from above and below requirements for healthy children. There is limited data, but it does suggest that advanced CKD are at increased risk of malnutrition that may be associated with low magnesium and trace element status. When dietary modifications are needed, rich sources of magnesium and trace elements may be reduced. And in the paper, we have a detailed table of this in the forthcoming publication. But for example, with diets with low animal protein intake, zinc intake may be reduced because meat and seafood sources are reduced. In diets with dairy restrictions of milk products, eggs and ionized salt, iodine may be reduced. Food preparation can also alter content. In the modifications of managing hyperkalemia, for practical purposes, potassium might require boiling, soaking and managing other cooking methods to reduce potassium, and this can affect green leafy vegetables, potatoes, root vegetables and legumes, and this may lower the content of chromium, copper, manganese and zinc. Long periods of boiling And soaking can also increase the content of fluoride in fluoridated waters. Absorption and metabolism of magnesium and trace elements are also altered by alterations by other nutrients, which will be found in a detailed table in the forthcoming publication. But examples of this of high fiber intakes can decrease cerium zinc intakes, and higher iron and calcium intakes can decrease zinc absorption. I am now going to hand over to Jetta, who will follow the next few clinical practice points.
Thank you, Caroline. So I think sorry about that. So moving on to the factors that might make dietary needs of magnesium and trace elements different in children with CKD compared to healthy kids. In addition to kidney function, there's polyuria, dialysis, and medications which may affect magnesium and trace element status. And specific to magnesium and trace elements, there are exogenous sources that can contribute to their intakes. All children may develop magnesium and trace element deficiency due to malabsorption or malnutrition, and this includes children with CKD. Then there are the reasons that are specific to CKD, for example, proteinuria and protein losses, and the trace element losses where they are bound to protein. Many medications can affect nutrient status. For example, loop diuretics can cause magnesium losses in the urine. And some phosphate and potassium binders, which are listed here, can affect the absorption of nutrients, especially magnesium, copper, manganese, and zinc. And tacrolimus is known to cause urinary losses of magnesium. And as well, some formula thickeners can decrease absorption of zinc. Urinary magnesium excretion decreases as kidney function declines. When the GFR falls below 30, homeostasis may no longer be maintained, and then hypermagnesemia becomes common. Children on dialysis have been found to have high blood concentrations of magnesium despite low dietary intakes. In dialysis, the blood and dialysate concentrations of magnesium determine how much is removed, as well as substances in blood that bind magnesium, for example, albumin. There are also medications that can affect magnesium status, for example, the diuretics I already mentioned. And phosphate binders, proton pump inhibitors, and the oral potassium binder SPS may decrease magnesium absorption in the gut. Then again, magnesium-based phosphate binders can contribute to intake. Then a few selected snippets for the needs of trace elements in CKD. Urinary fluoride excretion decreases as kidney function declines, which causes a risk of excess. The fluoride content of local water determines fluoride intake, and children who drink large amounts of water may be at risk of excess. Then, of course, swallowing of toothpaste and dental treatments with fluoride can contribute to intake. Also, iodine accumulates with decreasing GFR. There may be the exogenous sources like PD catheter cleaning solutions and HD logs, and iodine injections in cystography. Very high exposure can actually lead to renal failure, in which case hemodialysis is the correct treatment. Then selenium is protein bound, and therefore losses may increase with increased urinary protein losses, as is found in nephrotic syndrome, where blood selenium concentrations are lower than in healthy controls. However, selenium losses with lower degrees of proteinuria have not been studied, and there are no measurable losses of selenium in either hemo or PD. For zinc, GFR, urine output, dialysis modality, and medication interactions affect the zinc status. There are varying losses in dialysis and potential losses with proteinuria. And rates of zinc deficiency range from 30 to 60% in children on PD and hemo, so they are quite common. These are most likely due to decreased intake as well as losses of protein-bound zinc in PD. Then malnutrition and loss of appetite are important causative factors in zinc deficiency as well. Then there are the environmental factors such as soil and water mineral content, which may impact the magnesium and trace element content of the diet. Soil composition, where the stable crops are grown, plays a role especially in intakes of chromium, selenium and zinc. And then fluoride intake is largely determined by local water fluoride content. And also the magnesium content of drinking water varies. Then moving on to assessment. Assessment is suggested in this order shown here, considering what's available and reliable. And biochemical assessment is reasonably low cost and often available, at least in the Western world. Physical assessment may also reveal trace element related issues like goiter, for example. And the dietary assessment of magnesium and zinc and selenium are somewhat reliable as based on the databases which we rely on to calculate the intakes, but most other trace elements are not quite accurate enough in the databases to really calculate the actual intakes from food. And since local soil determines stable crop trace element content, it's not really feasible to actually calculate the intakes. First of all, routine biochemical assessment of trace element status is not indicated. However, biochemical assessment of magnesium is suggested in those with hyperkalemia, hypercalcemia, and those with signs or symptoms of low or high magnesium levels. Low magnesium levels impair PTH secretion, which may cause low calcium levels, and therefore measuring magnesium is suggested. And in addition, low magnesium levels may increase urinary potassium losses, and for this, again, magnesium should be measured and hypomagnesemia corrected if there's low potassium level which does not respond to potassium supplementation. Then we suggest to consider trace element biochemical assessment if there are signs and symptoms of deficiency or excess. A couple of issues in more detail. In clinical suspicion of iodine deficiency or excess, a 24-hour urinary iodine is the preferred diagnostic test of iodine status, but with a reduced GFR, a blood test is likely more accurate. And the assessment of zinc status should be considered if the child is not growing properly. Also, if there's EPO-resistant anemia, then zinc and copper should be measured as their deficiency may cause anemia. In addition to the signs and symptoms of deficiency or excess, there are certain risk factors that prompt us to do biochemical assessment. And these include the use of medications that may impact magnesium and trace element excretion and absorption, specifically calcineurin inhibitors that lead to magnesium wasting. Then magnesium-containing medication can affect magnesium status, for example, some magnesium-based phosphate binders. Some trace elements interfere with each other's absorption, and if zinc and copper and iron supplements are given together, they might not be absorbed quite as efficiently. Then we need to be mindful of the use of adult formulas and nutrient supplements because the trace element content may be too high for the needs of children. And in kids who drink large amounts of water, there's a risk of fluoride excess if the local water is high in fluoride. In children with proteinuria, there may be a risk of deficiencies of zinc, copper, selenium, and magnesium. And finally, in those on hemo, there may be a risk of deficiency of selenium, zinc, and copper. And just a reminder that magnesium and trace elements should ideally be measured in the fasting state when there's no acute illness, and if the child is on hemo, then bloods should be taken before the session. And markers of inflammation, for example, C-reactive protein, should be measured when assessing trace element status, because inflammation may cause redistribution of the trace elements in the body, and the results in blood are not reliable. As for physical assessment, the signs and symptoms can overlap with clinical manifestations of CKD. For example, impaired growth, poor appetite, vomiting, and diarrhea. And when these are present, then the deficiency or excess of trace elements should be considered. Especially if there's poor growth, the biochemical assessment and evaluation of dietary and supplemental intake should be considered for magnesium, copper, iodine, manganese, and zinc, since the deficiency of these may have a negative impact on growth. Both iodine excess and deficiency can cause hyper and hypothyroidism, and the risk is greater in CKD than in the general population. And due to this, physical assessment to evaluate goiter and screening for signs of hypo and hypothyroidism is important. In assessing iodine status, one should also consult an endocrinologist. Then for the dietary assessment, some low intakes have been reported, especially for magnesium, copper, selenium, and zinc. And the risk of low intake is higher in children who are not supplemented with formula or nutritional supplements. Most nutrient analysis program databases are incomplete for trace elements, which makes quantification of intake unreliable. Excuse me. And the databases generally contain sufficient information for natural sources of magnesium, selenium, and zinc, but even for these, additives are usually not included. And this is why we've added the clause when information is available here. In any case, a complete dietary assessment should include intake from food, drink, that's including water, and formulas and nutritional supplements and medications. And we should also consider the effects of food preparation and dietary modification and nutrient interactions and malabsorption. Then the exogenous sources and non-prescribed products should also be taken into account when we estimate the intake, even though we can't quantify how much may be received this way. Then for the last part, what do we actually do with the patients? We want to optimize nutritional intake before considering supplementation. We suggest using age-appropriate formulas and nutritional supplements to avoid the risk of nutrient excess. If your best choice is to use adult formulas for children, you need to calculate how much you can give so as not to give excessive amounts of any trace element. Supplementation with zinc, selenium, and copper may be indicated when there is clinical or biochemical evidence of deficiency. We also suggest to avoid high regular intakes of seaweed due to its high iodine content, and to restrict dietary and supplemental iodine if there's iodine excess-induced thyroid dysfunction. We also suggest to adjust dietary and supplemental intake of magnesium to maintain blood magnesium within a safe range. This safe range includes mild, asymptomatic, low and high magnesium. We know that slightly elevated magnesium levels are really common in CKD. So the mildly elevated magnesium levels, if there are no symptoms, can be tolerated. In this table here, you can see what is considered mild and what's considered moderate to severe. Of course, in acute severe hypomagnesemia or hypermagnesemia, we need to correct the blood values because these can be life-threatening and they do require rapid medical intervention. But magnesium supplementation should be used only in proven biochemical deficiency and not based on dietary intake alone. Changes in magnesium management should be based on trends of serial results rather than any single result. There can be a lot of fluctuation in the blood levels and we don't need to react to every change if it's not a life-threatening situation. And moderate and severe hypomagnesemia should be managed with supplementation of magnesium salts. Magnesium is known to cause diarrhea, and for this it's better to give it in 2 to 3 doses per day instead of a single dose. Now we will illustrate the management of magnesium and trace elements in CKD with 2 case studies. So please go ahead, Caroline.
Thank you, Jette. So our first case study is a teenage boy who presented late with a very high blood pressure and underlying CKD. Management will move from conservative treatment to dialysis and will focus around a very restrictive intake. At time point 1, this young man was about 15 years old. He lived with his parents and was very active. As I said, he had chronic kidney disease, very high blood pressure, but also autism. And at this point, he was managed conservatively. Anthropometry assessment of growth showed that he was proportionate when you look at his weight, height, but also his BMI and his Z-scores. He had laboratory values represented deteriorating kidney function with an increasing urea and creatinine and decreasing EGFR. He had a variety of symptoms that included worsening appetite, increasing tiredness, nausea and constipation, and medications were used to manage vitamin D, add fibre and blood pressure. And at this point, he had no nutritional supplementations. At time point 2, this young man was now 16 years old. He continued to be very active with his swimming, and he'd also started peritoneal dialysis. He remained proportionate in his growth, and his Z-scores were actually closer to the 0 mark. His laboratory labs represented the management of peritoneal dialysis, but his urea was actually improving. His symptoms were also improving in terms of appetite and tiredness, but they remained a problem. His medications had increased to not only include vitamin D, fibre and constipation, but also EPO, potassium binders and blood pressure. And he had also commenced on an oral nutritional supplement.
So, how do you assess nutritional adequacy in a young person?
So, in this situation and with young people, you can actually employ all 3 aspects of looking at adequacy. First one being biochemistry. We can look at normal kidney function and also where there are signs and symptoms, as they were in this case study, include the addition of nutritional markers when appropriate. We can also ensure that physical assessment includes robust review of signs and symptoms by clinical exam and discussion with the young parents and young person, and also any potential and nutrient medication interactions. And also we can look at dietary intake. And taking a pragmatic view, you can look at 24-hour recalls with young people, which is probably most practical, but also you can look at more detailed in-depth nutrition diaries for longer periods of time where there are periods of concern.
So what is the impact of dietary modifications?
In this case study, there were multiple dietary modifications. If we look at the first time point, this young man was having modifications for no added salt, potassium and phosphate. And if you look at his diet history here, you can see he had a very limited intake. So although he was having regular meals and a snack, there were limited options and variety. There were some processed foods, and he had very specific likes and dislikes, and he was really struggling with these modifications. There was also increased high anxiety from the parents at this time to get things right, to try and manage his underlying conditions, and particularly the very high blood pressure. If we look at dietary assessment of time point 1, you can see here that the energy intake is low and that we're showing signs and risks of deficiency for magnesium and trace elements. There was reduced food preference and there was reduced sources of magnesium and trace elements, although the proportion of energy to protein ratio was good. If we move on to time point 2, so a little while later, the same restrictions were in place despite dialysis starting. And this was largely related to parental anxiety, being worried about relaxing the restrictions, particularly the potassium, which we wanted to do first because these were the foods that this young man was missing most. We did manage to increase the variety and content of the diet, and we were increasing more snacks and more home-cooked foods. But there were still very specific likes and dislikes, and the restrictions remained more in place than we would have liked. However, when you look at the dietary analysis of this, what you can see is we managed to increase the calorie intake and protein intake suitable for that for a child on dialysis. And you can see here from the intake now compared to the intake before, although there are still some risk of deficiencies for magnesium and trace elements, these were much better than the previous assessment prior to dialysis.
Okay, so how did you intervene with a young person with nutritional risk?
So I'll demonstrate this in the next few slides. The first, just a reminder of the overall assessment that we did. When we were considering our interventions, we had discussions and made sure we took into account looking at the growth, and this child was proportionate and growing along the centiles. The biochemistry, which was representing deteriorating kidney function and deficiency of nutritional markers, in particular zinc. The physical signs and symptoms, the worsening appetite, energy intake, nausea and constipation that needed some management, and the multiple diet restrictions and limitations of food-rich sources of magnesium and trace elements. So this led us to a combination approach, firstly looking at dietary modifications and advice with food first principles. We wanted to try and increase energy intake using food sources. We also wanted to try and optimize nutritional adequacy by increasing the variety in the diet, minimizing or rationalizing the modifications, particularly the potassium in this case, because the laboratory levels were better, the dialysis was doing its work, and these were the foods that this young man was missing most. We continued to try and minimize processed foods to help manage phosphate intake, but we also wanted to manage an overall good intake and balance and calcium to help with overall bone management as per previous clinical practice guideline recommendations. As we mentioned earlier, you might not necessarily always need to use multivitamin and mineral situations for magnesium and iodine, but we were looking at introducing one despite the food first principles later on, because despite this, there was still a varied diet that was showing nutritional risk across the board of many vitamins, minerals, as well as trace elements and magnesium. Some of the considerations that we needed to think about in terms of this intervention was that, do you look at an over-the-counter supplementation or a prescribable one? And fortunately in the UK there are no renal specific multivitamin and mineral preparations. Therefore we have to use the one that's closest in age appropriateness and lowest in vitamin A, and in this case we actually used an adult supplement on alternative or every 3 days. In terms of relevance to the case study, we used a multivitamin and mineral because we didn't need energy and protein, but there was persistent poor appetite and intake and risk of deficiency with serum biochemical lab markers showing zinc deficiency. The food first principle is to ensure quality and adequacy, and also was a shared decision-making discussion with the family and the team, and the parents were very keen to do everything they could with food before we use supplementations.
And how would we assess and monitor magnesium and trace element adequacy?
Assessment and monitoring can be summarised in the 5Y principle. So what we would look at first is the holistic complete assessment, looking at adequacy of growth, assessment of biochemistry, physical assessment and dietary markers and intake, any potential drug and nutrient interactions, the impact of dietary modifications and the management changes that are needed, and the tolerance of any interventions that we had, which would include the change to dialysis and the introduction of supplementations. We would do this in clinics and on the phone in between, if support was needed to just reduce anxiety, help adherence, check tolerances, and identify any ongoing challenges that the family may be having. And this may increase with more frequency with recent changes in treatment modes or interventions, and also if there was high levels of anxiety that needed further support. I am now going to move over to Jetta, who is going to look at case study 2.
Thank you. So let me introduce Adam, who is a baby of 10 months with a progressive congenital kidney disease. He's on feeds, takes about half from the bottle and some tastes of purees, but he needs top-ups via a tube. And when we first meet Adam, his milk intake was 950 milliliters of standard infant formula. So that's about 120 mils per kilo. He was taking this 6 to 7 feeds per day. He was presenting with symptoms of nausea, poor appetite, and occasional vomiting. And his labs show elevated phosphate and urea levels, but potassium was fine. As we needed to decrease the protein and phosphate intakes, we are decreasing the amount of formula powder in his feed and adding some energy modules. This already leaves us with a suboptimal intake of magnesium. On top of that, he's not able to take in all the formula we prescribed. So intakes of magnesium and now also zinc are below the recommended intake for healthy children. Highlighted here is also the fact that the database was incomplete for chromium, so the information was available for one feed but not the other, so estimating actual intake is impossible. And since fluoride content of the feed is determined by the water that's used in preparing the feed, we do not calculate the intake of fluoride. Then Adam developed hyperkalemia and we switched to partial renal specific formula combined with a high energy infant formula. He was still presenting with symptoms of nausea and poor appetite and vomiting. At this point, he was started on PD. The intakes of the trace elements were all sufficient with these feeds, so there was no need for supplementation. And this is generally the case, that feeds provide enough trace elements and no supplementation is needed. We then had to do some feed changes, first due to a suspicion of cow's milk allergy, and next due to hyperkalemia. So these are feeds number 3 and 4 in the table. And at that point, with feed number 4, we again ended up with a low magnesium intake after diluting the formula and using energy modules. The labs are shown above in the green box, and they show that his magnesium blood levels were just fine. So there's actually no need to supplement, even though the calculated intake of magnesium seems low. As we talked about, magnesium accumulates in CKD, so we need to be extra cautious about giving it as a supplement. And to further demonstrate how we deal with magnesium, here is a lab curve of one child's blood magnesium levels through time. The red lines here represent the reference range. And this is a child with a congenital nephrotic syndrome of the Finnish type. And these children have massive proteinuria from birth, and this causes major losses of magnesium as well. You can see that in the beginning, his magnesium blood levels were low, even though he got a supplement. We usually use milk of magnesia in infants. Then you can see how his magnesium blood levels rise after bilateral nephrectomy and the beginning of dialysis. And they remain high even though he's not receiving any supplemental magnesium. And the magnesium intake from feeds was roughly the same throughout this whole time. And then the next fall in magnesium levels comes when he receives the kidney transplant and starting the immunosuppressive medication that leads to magnesium wasting. Again, he was started on a magnesium supplement, but it took a while to get the blood levels sufficient. Since then, he has been on magnesium supplements. We have been able to reduce the amount, but he still needs it to this day.
So, how would you assess and monitor magnesium and trace element adequacy in an infant?
Well, first we assess the infant by measuring height and weight and plotting these on a growth chart. In our center, we also do biochemical assessment for magnesium quite regularly because most children have some risk factors for deficiency or excess. And we also monitor zinc and selenium levels to guide with supplementation as needed. We also assess feed intake and vomiting and assess magnesium and trace element intake from feeds for, well, mostly magnesium and zinc, selenium, and maybe copper. And we want to use the actual amounts that are given and not just our feed prescription. We also check for physical signs of any deficiency or excess, and if needed, do biochemical testing based on these.
So, how would you intervene with an infant with a magnesium or trace element nutritional risk?
First of all, we always promote oral intake first. As with the changes of feeds, we need to focus first on providing the needed energy and protein and to get the phosphate and potassium intakes to suit the child's individual tolerance. After that, we can see what we can do about the minerals and trace elements. Children on feeds will likely not need a mineral or trace element supplement, but in special cases it might be necessary. And of course, we monitor what we do, so assess food intake and tolerance and physical and biochemical markers of deficiency or excess. So as an overall summary, CKD can alter magnesium and trace element intake and biochemical status. The requirements may differ in children with CKD compared to healthy children. And we want to promote health, not only treat a condition. And we also want to prevent comorbidities, for example, cardiac disease and bone disease. This concerns, for example, hypomagnesemia, where there's an increased risk of cardiovascular disease and vascular calcification and decreased bone mineral density. And on a last note, the dietary modifications that are necessary for urea, phosphate, and potassium management, they may reduce magnesium and trace element intake, but should not compromise their status. And we are, of course, thankful to the Magnesium and Trace Element Working Group for their hard work, and also wish to thank the whole Pediatric Renal Nutrition Task Force and the Delphi respondents for all their helpful comments. And now we are moving on to a question and answer session, so please send us your questions.
First of all, thank you. I said this when you couldn't hear me, but Jenna and Caroline, thanks for that wonderful presentation. It was really great having cases to help illustrate the approaches that are outlined in the guidelines. And but let me go on to the questions. Some excellent questions. The first one relates to a patient post-transplant with low magnesium levels, and the patient has developed diarrhea, and wanted your suggestion on how to address the low magnesium but avoiding the diarrhea.
Do you want me to take this?
I was going to say, would you like to start, Jetta?
Okay, I will start. So it is a tricky one. It's always best to divide the doses in 2 to 3 doses per day. That might help some. Otherwise, actually, it's good to be cautious about correcting the diarrhea, because you're also affecting the absorption of the immunosuppressants. So if you correct the diarrhea very quickly, then that could affect the immunosuppressant levels in the blood as well. But to be honest, quite a lot of our patients do have some level of diarrhea or loose stools with the magnesium, and we can't always help with that so much. Pectin might be something to try, but it doesn't always help.
It's also useful to take into account the other medications that might be contributing to the diarrhea, as well as the magnesium supplementation, for example, MMF. And sometimes there might be a wider team discussion needed to think about how you manage all of it and to try and reduce that diarrhea, but also ensure absorption of other nutrients.
Thanks. I must concur. It is a challenging topic, but I like the advice as well. There's a couple of questions related to elevated magnesium in dialysis patients. So how should that be managed? One relates specifically to a hemodialysis patient, and one relates just in general in a dialysis patient. What do you recommend?
Well, for feeds, I have never actually had to make any feed changes due to high magnesium. So the magnesium levels might be slightly elevated, but they've never been quite so elevated that we actually need to make any feed changes due to that. But if you had to, then you would do it as you would for feed changes for potassium and phosphate, so that you sort of dilute the actual feed and give energy modules, and then you would need to supplement other trace elements and vitamins.
And likewise with Jetta, I've never had to reduce dietary magnesium, but it's also useful to be mindful of checking the supplements that you're using. So the appropriateness of the feed and any micronutrient, vitamin and mineral supplements that you're using, to make sure that there aren't massive excesses of magnesium and maybe other trace elements. It's often mild rather than severe in the cases that I've looked after as well. So it's been more looking at that pragmatic approach rather than jumping in and changing something that you might not be able to affect. And taking out a multivitamin may cause many other potential or worsen other deficiencies.
Excellent. We have another question. The person asking the question mentions that they're from Mexico, and they ask, what kind of supplementation would you use in children when needed? Would you use liquid multivitamin or gummies?
I think it depends on the age of the child and the composition of the supplement that's available. There's many countries that don't have renal specific medication, so you need to look at what you're looking at for that individual child, what the challenges and issues are, what the potential wider challenges and issues may be, and what fits best. So for example, in terms of liquids, you might not want something with energy and protein, as in the case of my case study, if they were already getting adequate energy and protein from the diet. However, in the case of a younger child or a baby like Jetta's, you want to find the most appropriate complete feed. I think that's probably a balanced answer. How my approach would be. What about you, Jetta?
Yes. So yeah, it depends on what's available and what we can do. If we need to put it in a tube, then that's maybe restricting what we can use. And sometimes we don't always have the perfect supplement to use. So the nutrient content is not always optimal for our kidney patients.
And the other thing I just thought of is with the liquid supplementations of the vitamins, you need to be careful that you don't give excess of the fat-soluble vitamins. And that was something that we discussed in great depth in the previous webinar.
Very good. We have another question. There's a patient with a rash and was discovered to have zinc deficiency and was started on supplementation. This is a patient with CKD. And when would you recommend rechecking zinc levels? How often would you follow zinc levels, and how long would you continue the supplementation?
So there's no firm evidence on that. In our centre, we tend to use a zinc supplementation for 3 months, and we would repeat those levels at 3 monthly. If the levels aren't where they wanted to be then we would probably do another period of 3 months, but we would be mindful about not overdosing and stopping when those levels normalise, but also taking into account what other supplementation was going on. You may want to measure more frequently, but normally our centre is a roughly 3-month rule. I don't know, Jetta, do you do anything slightly differently?
Well, we also check the levels usually every 3 months, and yeah, we would adjust the supplementation based on the blood values.
Good. Well, that's very clear. There's another question here. In refeeding syndrome, thiamine and vitamins are indicated, but there may be a risk of excess trace elements in kidney patients. How would you manage this issue?
Jetta, jump in when you're ready. It's difficult because the evidence isn't there, and I think you need to look at every patient individually and look at that case and make sure that you're measuring appropriately. And I guess this is where your laboratory values would be important, but we appreciate that not every centre can measure laboratory values, and you may need to look at what percentage your excess is and discuss that with the wider team to make decisions that keep that child safe. Jetta, do you have anything to add for that?
Well, thiamine supplements are available as an individual supplement. So if that's the only one you need, then that's an option. And there are vitamin B complex and vitamin C supplements that can be used without the trace elements. So I think that would be a viable option in this scenario.
Well, I really like to thank the audience for the many excellent questions, challenging questions, I might add. I think this is going to show that everybody out in the world is facing some very similar challenges, and thanks to our speakers for addressing these difficult questions. The next question starts out by thanking you for your excellent talk, which I must agree on. And then which magnesium preparation do you prefer for oral intake? mentions the active ingredient. What would you prefer for the active ingredient?
We tend to use magnesium citrate as a first choice. And for infants, the milk of magnesia, because that's easily administered via a tube.
I think it also depends on what's available in your centre, and making sure again that you check this with the MDT and then grading it in appropriately. But we would use something similar.
Very good. There's another question related to refeeding syndrome in CKD patients. Would you expect magnesium, potassium, and phosphate to get low, or not so much because of the kidney disease?
That's a tricky question. I'm not sure if, Larry, you might be the best to answer that one.
I would say, it's going to be a balance. Literally, patients with the more advanced their CKD, especially if they're not on dialysis, the more likely they are to have retained magnesium, potassium, and phosphorus. But on the other hand, if they haven't been receiving much of those minerals or elements, they're certainly still at risk for refeeding. So I think in that case, really just monitoring is going to be your best approach. Really, anybody can develop hypophosphatemia with refeeding. Anybody can develop hypokalemia with refeeding. The risk is probably lower in a patient with advanced CKD, but certainly there's still a risk, and I think careful monitoring. And obviously there's refeeding and refeeding. There's some patients that, are horribly malnourished, and the risk of refeeding syndrome is much higher. Of course, in those patients, you're probably going to start out with very gentle refeeding to try to avoid those complications. But in the end, it's going to come down to monitoring. There's another question, another magnesium question. In the graph, you showed the child on dialysis at high magnesium levels. How do you manage that? I know you somewhat addressed that earlier, but maybe in the context of the graph and maybe some additional comments.
Yes. So what we did, of course, was stop the supplementation, but that was actually done already when the dialysis was started. But despite that, the magnesium shot up. We just actually tolerated the high magnesium level because there was no symptoms. So there's really not that much you can do about that high magnesium unless you're completely changing the feeds, and that gets a bit tricky. So with an asymptomatic child, then it's okay just to follow.
Yeah, I agree with that 100%. Obviously, if they were getting exogenous magnesium beyond their feed, some medication or supplement, you'd want to eliminate that. But we very commonly tolerate mild asymptomatic hypermagnesemia in dialysis patients. Let's see, there's someone asked about the slides, and just a reminder, the recording will be available on the website in a few weeks, so you will have access to that. And then a further reminder to fill out your evaluations when you get them. You'll be receiving an email, anybody who registered. And which lab value do you use to confirm vitamin A toxicity?
That would be serum vitamin A that we measure. Yep.
And your reference range for your lab, because they can differ across the world. and between labs, because the assays can be different, but we would use the same.
So it can cause a lot of toxicity, so it's good to be very cognizant of that. Let's see, there's one, the speaker, the audience member asks about risk of iodine deficiency due to a very low salt diet. And is that something that you worry about or screen for?
Well, that would be an excellent research project. we don't really know. So we know that iodine accumulates in CKD, which is why we do not supplement with iodine, even though the calculated intake might be low. But we just don't have the data in children, unfortunately.
And the databases aren't always complete also. So then it would be going back to, you know, good old dietetic by looking at the different food groups and making just, you know, trying to encourage a varied diet. But as Jette said, it's a huge gap in evidence that needs to be looked at in research with decent numbers across different ages and stages of disease.
That we don't have give the audience another 30 seconds, but I think we've had all the questions answered so far. Really excellent questions. It's a challenging area, and thanks for those excellent responses. And I want to thank the audience for their active engagement and coming to the seminar. I'd like to thank our two wonderful speakers for the excellent presentation and fielding all of those questions. And please remember to fill out the feedback form, which will be emailed to you after the webinar. We really want to know, you know, how we can make these webinars as helpful as possible. There will be upcoming webinars, and you can look at the site and you can follow this program on LinkedIn and X, and obviously at the website, which has, the website of course has incredibly helpful resources, both all of the clinical practice recommendations that have been published, to handouts for patients, and information for practitioners. So please go to the website and use those resources. And that I'll conclude, and thank you very much.
Thank you.
Thank you.